All right, as a point of information, chemotherapy drugs can be either irritants or vesicants. Irritants can damage the inner lining of the vein, but not so much the tissue, okay? Whereas vesicants, or that term, really refers to local tissue breakdown and necrosis, as you saw in the previous picture. It's extremely important when you have a patient that's getting peripheral chemotherapy, which isn't all that often, but sometimes is done, to really watch for these signs of problems with potential extravasation, because a vesicant has really, broken down the tissue around where it's infusing, because it's infiltrated and because of its vesicant properties. And in that case, the infusion must immediately be turned off. And if swelling persists, there may be very specific protocols for drug-specific extravasation procedures. So in most agencies, you're going to contact the chemotherapy nurse or the chemotherapy team. And occasionally, I guess it might be relegated to a physician or a nurse practitioner in an oncology office for more of an outpatient chemotherapy. But you definitely want to stop it. And if you don't know the protocol, refer to any protocols for that, and or notify the physician immediately. So here are some other methods that we talked a little bit about before. And hopefully you'll get to see some of these when Miss Cade brings in some examples of things when she's here on next Tuesday. But this is a central access device, or you may hear people refer to it as a vascular access device or a portacath. And with it, you can see there is a actual under the skin kind of a portal. You see that in the purple there. And that's underneath the skin and implanted surgically, and it has a tube coming off of it that then goes into the superior vena cava, or a large vessel headed towards the heart. And this is for frequent, continuous, and or intermittent administration of chemotherapy. And it can also be used to administer other fluids. And often, as you'll hear, many of our patients with oncology have to get blood transfusions, may have to get electrolyte replacements, which are better administered through a central line versus a peripheral line. And even for repeat scans, they now have ones that if you have a CT scan with infusion, you can actually get that through what's called a power port, a specific portacath that is made to withstand the pressure of getting that dye infusion pumped into your vessels. And then lastly, one major feature that's great about these is most of them will draw back blood samples. And so for these patients who are very, very sick and have to have blood draws frequently, often they can have it done and should always really have it done through their port versus putting them through the painful peripheral phlebotomy sticks for blood draws. So chemotherapy can also be given regionally, which means that they deliver the drug directly into the tumor site. Sometimes that is a specific injection of something that is given with the physician that's done it. You can give higher concentrations of the drug. And then sometimes patients will get regional administration directly into it from a pump that's placed under the skin and is set up to be ongoingly pumping chemotherapy into the tumor itself. It can be also regional delivery can be done through an artery. So it could be given in an artery that is really giving the blood supply to the tumor that is helping it keep multiplying. And so the thought there is if you cut off the blood supply, the tumor dies. And so that doesn't happen very often, but that there are some times when that is a very good method for shutting off its supply of blood and nutrients, and therefore the tumor will just necrose and die and can be removed. And then intraperitoneal, that means giving a drug directly to the peritoneal cavity. And usually that's done when you have metastasis in terms of lots of growth in and away from the tumor in different organs in the abdominal or the peritoneal cavity. And so they will actually fill that up with that chemotherapy and allow it to have a certain dwell time, which means it would stay in the peritoneal cavity for, say, 1 to 4 hours, and it might be as much as 1 or 2 liters of fluid that's injected. And then once that's set there for that dwell time, then it will be drained back out of the peritoneum. And here's kind of a picture of how that might be set up and how that would look. Other regional delivery methods include intrathecal, which means they give a lumbar puncture in the spine and inject chemotherapy into the subarachnoid space. There are certain types of cancers, some of your leukemias, lymphomas, and occasionally some tumors as well. Intraventricular means they have to give the injection directly into a ventricle of the brain. You remember me talking about that through the brain itself. Often you can't give drugs in your blood vessels and have that go across into the blood-brain barrier. So because of that, sometimes intraventricular injections right into the ventricle of the brain is the only way to get the drug to the brain. And then intravesical is given directly into the bladder. There are some bladder cancers in which again, it's kind of like the peritoneal cavity, where they would let the agent stay in there for 1 to 3 hours. They would probably put a catheter in the patient and then clamp the catheter so that they flushed the chemotherapy into the bladder and then clamped it so that it stayed in there. After that dwell time again, then they would unclamp it and allow it to drain out of the bladder into the bag. So here's some pictures of intraventricular and intrathecal. And so how does chemotherapy affect normal tissue? Chemo cannot distinguish between good cells or bad cells. So part of the issue of why people respond to chemotherapy is their body is responding because there's cellular destruction to regular cells in their body, creating lots of fatigue, anorexia, taste alterations, and a host of other weakening conditions that come from just cells in their body and blood cells, as we'll find out in the body, that are highly affected in a negative way, and cell death because of chemotherapy. Drugs can be given in combination, as I mentioned before. Dosages are carefully calculated according to the patient's body surface area. So everybody's amounts are very unique to their body size. And often selecting drugs with different modes of action minimizes the occurrence and severity of adverse effects. So you wouldn't want to give somebody 2 drugs that kind of kill cells exactly in the same way, because then you would get a multiplied effect of killing cells, and could make the symptoms very much in a worser fatigue and worser condition afterwards. And then usually chemotherapy is not interrupted Basically, you keep trying to go through it, and even if you have to delay it for a day or two until the person's condition or their blood counts or things change, you really, really want them to get the full intended dose. There are times, though, when a patient just absolutely cannot tolerate something, or they have, some type of an allergic reaction to a particular drug, and the treatment has to be interrupted or stopped. So let's talk just briefly about radiation therapy. This is a local treatment only. It's one of the oldest non-surgical ways to treat cancer, and just about 50% of cancer patients are going to receive radiation therapy. Normal tissues are usually able to recover, but as we talked about that a little bit, we talked about the throat and neck and lung cancer in particular. There are some problems. Again, cancer cells are more likely to be permanently damaged, whereas other tissues are better able to recover. The dose of radiation, again, depends on the tumor size, the type, and the treatment setting, and how precise of radiation therapy equipment that they keep there. It can be delivered externally or internally, meaning it's either being shot at you, or it can actually be inserted into a body cavity area and done as well. It can be used either as primary or really very definitive therapy, like we're really trying to cure. It can be done as like an extra thing on top of getting chemotherapy, just to kind of help support the cell death of whatever tumor it is. Some people may be put on it as a prophylaxis type treatment, just to kind of make sure that something doesn't grow in an area. And again, as we've talked about before, it can be more from a control and a palliation standpoint too, just to help the patient either periodically get a little bit to kind of keep it from growing back at a faster rate in terms of control, or palliation to kind of make the situation or the area feel better and have better quality of life. So external radiation is called teletherapy. It's the most common radiation treatment, and the patient is exposed to radiation from a megavolt machine, and these are some of the examples of the types that you see: Gamma knife technology, cyclotron, and then linear accelerator. So just those are just names of the kinds of ways and that they are delivered. This is a linear accelerator, and you can kind of see how the patient is positioned on the treatment, and it's very much focused on head and neck cancer for that particular person in the picture. The Gamma knife is very, very precision oriented to kind of direct radiation, as you can see in that picture, very much at multiple angles from different ways to really pinpoint and precisely create cell death in an area that is pinpointed. You see this a lot of times with head and brain tumors, just because sometimes they're very tiny and not easy to get to surgically, but with this type of procedure you can be very, very precise and hit a very small area much better. So internal radiation is called brachytherapy. Sometimes you see them implant radioactive materials very close to the tumor itself on the inside of the body. In that way, they may have minimal exposure to healthy tissue, and sometimes it might be used in combination of internal and external. But you can kind of see there's some radioactive seeds or little bitty metal implants over on the first picture to the left. And then other ones of the pictures are showing where something has been inserted into a body cavity. And for those, often they may have to retain that radioactive material insert in for a period of time. Sometimes, depending on where it is in the body, they may have to lay flat for a period of time. And then after it's been a certain time interval, then they may have that removed. And the person may be radioactive for a period of time, in which caregivers have to be careful